Good afternoon, everyone. We thank you for joining us in the Black Health Trust for this wonderful Sunday afternoon. And we have an outstanding speaker this morning. And we're going to present a topic called Addressing Issues of Suicide, Part 2. And especially we're concerned about how this affects our young people. But we're also going to start considering for our next 2 weeks where we're going to talk about things that may have started several thousand years ago that affect our daily news and what's going on in the world. So I want to just show a very brief video before I introduce our topic and speaker. Simon? It's not bad.
So you think you know Wix, but do you really?
Stop it. Thank you very much. This is just an introduction for what the series we're going to start from Genesis next week with a history of the Middle East, and then followed by 3 general and admiral officers of the U.S. military the following week. But today's topic is the one at hand, and we're very concerned about what's happening in our community. And we're concerned about the fact that so many of our children and youngsters are coming in to commit suicide and other acts. Our wonderful presenter this morning is Dr. Donna H. Barnes. She is currently the founder and CEO of DHB Wellness and Associates, LLC. She's been a faculty member at Howard University Department of Psychiatry, and she's a nationally renowned expert in dealing with suicide prevention, which is a major goal of the CDC. We've had her in several weeks ago, and we needed to have her back, and she's here. I welcome her very much, Dr. Donna H. Barnes. Thank you for being here today with us.
Thank you, Dr. Maxey, and thank you for all who came into the room. Sometimes I just don't know where to begin, but I can start in the beginning. I founded an organization back in 1998 called the National Organization for People of Color Against Suicide. That was founded because there was myself and two other people who had lost sons to suicide in the beginning of the 1990s, 1990s. And we didn't really have anywhere to go to, as parents who thought they had done everything they were supposed to do, and then we lose a child to suicide. It's very devastating, especially when you don't have anyone to talk to. There were plenty of white organizations, plenty of support groups that we would integrate, but we just needed to be around people who looked like us. It was myself, Doris Smith out of Atlanta, and Les Franklin out of Denver. We came together and founded this organization. And we were doing very well for 10 years. And we gave conferences in major cities every year for 10 years. I think our last conference was in Boston in 2010. So we had a good run. Going to these communities was very interesting. When we first started out, we got some pushback. They said, why are you here? Why are you here talking about this? This is something we don't do. You're only going to put the idea in kids' heads. But we kept on pushing. And eventually, people began to accept us. One moving story was when we went to North Carolina, Durham, North Carolina. One of the attendees was a maintenance man at a local school. And when he saw in the paper that Nopcus was coming to town, he went to the administration and said, I know I'm just a maintenance man, but I really need to go to this conference. I talk to kids every day. I don't know how to address their issues. And many of them have talked about suicide. So they gave him permission and they paid for his 2-day attendance. Fast forward, and I think I mentioned this last month when I was there. At Howard University, I worked with the medical students, and I did seminars on how to treat your suicidal patients. And I also did seminars with psychiatric residents on risk management in reference to suicide. So to begin with, I'm not going to talk about children. I'm going to talk about suicide in general. We talked about kids last week. The biggest thing in reference to children is to know how to communicate and allow them to talk with you and allow them to have a voice. And sometimes you have to come down to their level. If they're on the floor, you get on the floor with them. I'm going to talk about it in general. Our community takes their own life differently than other communities. We don't really do it the traditional way. So when the numbers are low, when I say low, they're not low to us, especially if it's increasing among kids under the age of 12 and among 15 and 25-year-olds, it's increasing higher than their white counterpart. So it's not low to us, but it's low to the general public. It's low to government agencies. It's low to people who want to work in the community, but look at other things that are taking out lives at higher rate, like strokes, heart attacks, HIV/AIDS, all of those things. So suicide is at the bottom of the list. So whenever Nopkins was trying to get funding, it was difficult. We did it for 10 years, and then I'm just amazed that we were able to last for 10 years, because it was very difficult to get funding when our numbers weren't as high as the white counterpart. And don't even talk about trying to get funding for research for Black Americans. So what we can do in reference to suicide prevention in our own communities is to stay ahead of the game. Just stay ahead of it. I think every organization such as this, the Black Health Trust, should do something in reference to suicide prevention and intervention. There are trainers in your area. You want to have some people trained on how to recognize the signs. You want to have people, you want to train trainers so that the trainers can go out in various parts of the community and train people on how to recognize the signs. That's very important, because people take their own life when they feel like they're not being understood, when life no longer has meaning to them, when they have no hope, when they can't see for the future, when they feel that nobody will understand, or they're suffering from a major loss, a loss that really meant a lot to them. An example would be like a concert pianist who lost the use of one of his hands. That's a major loss, because his profession was being a concert pianist. Losing your marriage, losing your house, losing another child, losing anything that meant a lot to you, and you have lost that. Many times it's difficult to try to go on, or to figure out how you're going to go on. Public humiliation coupled with shame can cause people to take their own life. So we kill ourselves in different ways. And what really used to sort of be a challenge to me is to explain to people when Nopkins was looking for funding that we kill ourselves differently. We have very high rates of drug-induced deaths. We have very high rates of accidents. We have high rates of homicide in our communities. Accidents, homicide, and drug-induced deaths. Suicide is lower. How many of those homicides are suicides? If you want to take your own life, just put yourself in someone in harm's way. That's what I'm trying to think of. Accidents and overdosing on your medication, overdosing on street drugs, because the coroners are going to certify it as an overdose or an accident. They do not certify suicide unless they're 99% sure, unless there's a note left behind, unless they jump from a tall building. And sometimes if they talk to the parent and the parents know that this drug overdose was a suicide because they were threatening to do it. Sometimes they will, with the parents' consent, certify it as a suicide. In reference to my case, my son left a note. Many people didn't think that he took his own life, and they couldn't understand why I had gotten into the suicide prevention arena, because they didn't think Mark killed himself. He just got in his car and drove it into the Merrimack River in New Hampshire when he was at school, away at college. He was in his second year at school. And so I could have easily said that it was an accident, that he drowned. But we are as sick as our secrets. I wouldn't be here talking to you today if I lied about it and said he had drowned. But he left a note to his roommate. And the note indicated, not that he was going to kill himself, but it was like, say goodbye to my mom, say goodbye to my dad, say goodbye to my sister. So it was obvious that he was distraught. We will never know. And as a survivor of suicide, you ask yourself a million times, what was it? What did I do? Was it something when he was 12? Or was it something when he was 16? What part did I, as a parent, have in his decision to take his own life? And when I work with parents who have lost someone to suicide, I feel their pain all over again because it's very hard for them to understand. I had a woman say to me, I don't get it. My son looked me straight in the face and said, Ma, I would never take my own life. And then 2 days later, he's hanging in the garage. Mm. Well, it's not that he didn't want to live. Most people want to live. You always want to live. That's your first thought, is living and hanging on. But when you're thinking of it, and when you live long enough, you do think about it, but it's a fleeting thought. And the next day you go back, you go to work and everything's fine. When you're thinking about it and you can't get to sleep, and you're reeling with all of these thoughts, how lonely you are, no one cares, I lost this, that. If that moment comes where your coping mechanisms break down, and I talked to you last time about those 4 things that need to be in place when someone decides to take their own life, when that happens and those things line up like lucky sevens, then there's nothing we can do. The only time we can interfere or intervene is if we have a general feeling that this is what they're thinking of. And then we can talk to them about death as an option. We can talk to them about that. Okay, I want to have a discussion. I know Dr. Maxey wants me to talk about children's suicide, but I did that last time. I want to talk about what's on your mind, what you know about suicide, what questions you might have about suicide. I can wait.
Our other moderator on the line is Dr. Hines. How are you, Dr. Hines?
Thank you. So the questions that I have, and you brought up several good points that maybe we could spend a little bit of time on. You were speaking about substance abuse as a method of suicide. Both, I think kind of in the moment and almost like chronically, that doesn't necessarily go recognized. And if you could spend a little bit more time in that space, because that one's one that I think is around us more than we realize.
Absolutely, absolutely. It's a slow death. Mm-hmm. And they're trying to escape life as they know it. And they think that taking their drugs is going to make them feel better. They do not want to be drug addicts. Nobody wants to be a drug addict. If they could stop, they would, but they're addicted. They're addicted. And we need to work on the addiction. But many times we work on the addiction, they get clean, and then they go back because there's something that was not dealt with. There's some hope that they're not being able to connect to. There's some reason for living that they can't seem to grasp. So they go back to the drugs to feel better, but it's a slow death. And when you're dealing with substance abuse, that really needs to be talked about. That needs to be talked about. Not so much that, you got to stop. You got to stop taking drugs. You got to do this. You got to do that. You got to start working out. You got to eat better. Stop talking to them as death as an option, because that's what they're doing. It's a slow death.
And while it is implied to explicitly say alcohol is just as much of an issue, it shows up in the same way, in my opinion, as some of the more illicit.
Yes, it's substance. Yeah.
Yeah.
It's a substance
But
abuse.
lots of times people make a distinction, right? Like they're like, oh, because I'm not using street drugs, you know what I mean? Like they excuse it, right? And I think as loved ones and family members, we sit around and watch it happen too, right?
This is true. And because, psychiatrists will tell you, and Dr. Clark chime in here anytime, that the alcoholism, if it affects your everyday life, and you can't get up and do what you're supposed to do, if it's affecting your relationships, your job, your lifestyle, then it's a problem. But many alcoholics can function, get up, go to work. However, someone was saying to me once that they don't believe in that alcoholics can be functional, because they may be functional in one area and very dysfunctional in another area, like trying to raise a family, trying to be a good husband. Somewhere in this alcoholic's life, it's just not working. Dr. Clark?
Can we unmute?
Hello, I'm here.
Okay.
Well, first of all, I want to applaud you and your agency's extraordinary efforts and generosity and selflessness in taking action around the issue of suicide. I think pointing out how many of the suicides in our community are not recognized due to prejudicial disinterest, or to it be associated with something that is commonly thought to be an accident. I remember Nathan Hale's description of quasi-morticide, when people put themselves in harm's way because they feel like their life isn't worth protecting. I think one of the things that's important moving forward is to look at what it is that life is worth living for, and the importance of love of self, and not having your locus of worth outside of yourself. And I think so much in our society pulls particularly youth, but also adults, into longing after things that they think are the ideal, the superficial projections that we see in media particularly. And in young people's media, there is a focus on brand loyalty and a lot of grandiosity that is impossible for most to achieve. And to have them recognize that that's really just superficial, and to understand the reality of where their locus of self-worth should be with self. Very hard to do when people are struggling with adopting their identity, which transitioning in the context of, a raging sea of hormones, a world of violence, a country of insane confusion in government. It's really hard for them to find that locus, and particularly for those who don't have stable parental objects. I mean, there's so much we can say about this. So I think as Black providers, having organizations such as your own, having the Black Psychiatrists of America, having National Medical Association, having Black Health Trust, and really giving our time to save the community, which is basically the basis for our lives, is so important.
Absolutely. Everything is suicide prevention. So you can start with all sorts of things that you mentioned, Dr. Clark. And I was so glad to hear you say that as a psychiatrist, that these are some of the things that we need to look at.
Oh,
Because I have, when I was working with the psychiatric residents and I did my seminars with them, my position was work with them about death as an option for at least 2 weeks before you even start changing their medication or working on medication. Because psychiatrists concentrate too much on medication.
Oh, goodness, yes.
And I understand it. They only got 20 minutes. So they come in, oh, I'm thinking of suicide. Well, what medication are you on? And all of that stuff. So I'm glad to hear you agree with that, because when they came to my seminar, it was not about medication. And they said, but we have to do that because if we don't, we could get sued, and all kinds of things. One of the things was admitting them. They would admit them if they just mentioned it. I can remember one resident was telling me that their patient came to talk to them, and he said, well, have you ever thought about suicide? He says, yes, I thought about it on Tuesday, or, I did think about it. So he immediately started putting paperwork together to have him admitted to the psych ward. And he said, Doc, what are you doing? I got to go visit my grandmother this weekend. I got all kinds of things to do. I promised my wife this and that. I'm not going to kill myself. You asked me if I was thinking about it. And so he stopped the process. But we can't be afraid that they are thinking about it. We can't be afraid if they talk about it, because many times you lose, some of you may have lost patients to suicide. And if you did, it's only because they didn't feel comfortable talking about it. Not so much you, but anybody, because they don't think anyone's going to understand. And many times they don't tell you as the doctor that they're thinking of suicide because they don't want to hurt your feelings. They like you.
That's
So
right.
The response of psychiatry
So
to suicide in the emergency setting is shameful. And unfortunately, for people in the African American communities who are don't have the privilege of having private independent services, but have to deal with public services, which are pressed and under the tyranny of the clock around providers' time, etc., and the misinterpretation of the involuntary detention laws and the brutality of the methods that are used to hold, tie down, isolate, strip search, etc., are horrifying. And you can understand just hearing about those things, never mind experiencing them, would shut a person down in terms of sharing any kind of feeling or thought. I've seen this happen over and over again. It is not true that mentioning suicide will put the thought in somebody's head. It's already there. It's in dramas, sitcoms, movies, operas. It's, suicide is a fact of life. It's in the woof and woof of our civilization. You are not putting it in anybody's head, and you are not prompting them to do anything. If anything, you are opening the door for them to release some of their thoughts and concerns.
let me pose a situation to you, Dr. Barnes and Dr. Clark and Dr. Hines. The two thoughts that came to mind. One, I am totally against people drinking alcohol. I think we call it ignorant oil. And I think it mentally and physiologically is worse than some narcotics. And what I used to do was say, if you have to be high, use marijuana. But I also understand now that there are different grades or types of marijuana, some of which give you an upbeat mood and some that depress you and give you a downbeat mood. And I wonder how much of that decreased barrier to suicide, some of it could be the rampant use of marijuana. That's one. And the other, as you were talking, and I had great empathy, how do you deal with that parent who has experienced loss of a child?
Well, I do run support groups with parents because nobody thinks about the parent. They think about the child and they try to work on prevention. Suicide is inevitable. It's going to happen. Like Dr. Clark said, they know, no one's going to put the idea in their head. Kids know if they can kill dogs and other people, they can kill themselves. They know this. So it's a thought that comes in their head, and sometimes they do it. But nobody thinks about the parents. So I do run support for parents, and they're 8-week sessions. So I have the beginning, a middle, and an end. And dealing with the parent is to let them talk about it. Let them talk about it. Let them talk as much as they want about their loss, about their guilt feelings, about the shame, the blame, the family dynamics. Sometimes families fall apart. Sometimes bring close together. So you allow them in a safe place with people who have gone through the same thing that they have gone through. So it's just giving them that safe place. So we talk about it, and I allow them to do that for the first 4 weeks because they need to do that. I don't want to throw any kind of logic or educational facts on them because they're reeling with emotions and they don't want to hear the facts. They don't want to hear, oh, you shouldn't feel guilty. They don't want to hear all of that. They just want you to listen and they want to talk. So I give them that space to do that. And then the last 4 weeks, we are kind of talking about some of the books they can read, some of what they're talking about that's best practices for healing. And we talk about some of the good things about their loved ones, because when you lose someone to suicide, the only thing that's on your mind is what you didn't do and what you should not have done. That's the only thing you're thinking of. You can't even begin to think about the good things. And I have to bring them to that. Think about the good things, because if you add up the bad things and the good things, you'll see that the good things are much longer. Let's remember the good things we did and not concentrate on what we should have done, could have done, would have done. But yeah, so it's a challenge, but I enjoy working with them.
Thank you.
The other
Okay.
aspect of bringing the group together is for them to know that they're not alone.
Absolutely. Absolutely.
That's so key. And in terms of the whole issue of addiction, what to use or what not to use, people are going to use, okay? People have been using since man walked the earth. So it's the question of whether or not they have the unfortunate genetic propensity for addiction, and or for some reason or other, whatever the reason, got into that unfortunate biological loop of reward, where there's so much reward to whatever substance it is that it creates a habit. And habits are deeply biologically ingrained and need to be fed. That's why, to understand the physiology and the biochemistry of dependence is so important to try to communicate to the lay public, because our bodies, basically pull us to continue to use a substance if there has been enough habitual use. It's very powerful with alcohol. It's pretty powerful with narcotics. I cannot speak to the range of cannabis products. That's not part of Western medical education. and my attempts to educate myself on it have been limited because of the limited availability. And there's a whole political science behind the whole thing. I won't go down that rabbit hole, but I do see amongst the participants that Dr. Lisa Curvin Jones is on online, or was, the one coherent lecture that I've heard about cannabis and the positive uses has been her lecture to I think it was the Region 1 NMA in Jamaica some years ago. So I'm kind of hoping that if she's still available, she'll say something to answer your question.
No, thank you so much. Are there any, Dr. Hind, are there any comments or questions in the chat?
There's a question in the chat from Dr. Sherrod, and it says, thank you, Dr. Barnes and Dr. Clark, for an excellent discussion. And do you either of you have any protocols for anticipatory guidance?
Okay, that's a loaded question. Guidance, tell me more.
Can we unmute Dr. Sherrod?
Guidance in dealing with a patient, guidance in dealing with a family member, a friend
Can we
who's.
unmute Dr. Sherrod?
There are plenty of protocols. It just depends on what are you talking about.
So often I'll say that I would imagine that if we're talking about some of these particular vulnerable populations, I know that we're not necessarily focusing on kids, but oftentimes that preventative, proactive discussions happen in like child visits and things of that nature. So especially as we're moving into this space where it's being discussed more frequently among children, maybe that might have been where she was going.
She's trying to unmute.
She can't unmute, yeah.
Let's just say you have a neighbor who's thinking about suicide, or an uncle, or somebody.
Or even, I think maybe it's because the anticipatory guidance is before you even know, right? So for example, is there a way to introduce this into your routine health checkups, even for your adult patients, right? So
I see. Okay, I see. We should always stay ahead of the game. This is why I'm saying that any organization that we belong to, hi, Dr. Sherrod, any organization that we belong to should at least have some sort of a safe place for them to come and talk. Because if you're thinking of suicide, you want to talk about it, but you don't know who you can trust. You don't know if they're going to judge you. You don't know who to talk to. So if you have a safe place for them to go, most churches have ministries. They all have ministries, and they have a health ministry, and they mix mental health and those kind of things in with the health ministry. It should be separate and apart. If you want to have a mental health ministry, have a mental health ministry where they can talk about it. Don't mix it in with the health ministry. There should be two different ones that they can sit and talk. Many times when someone is thinking of the fact that they have no future, they have no reason to get up in the morning, they feel lost, let them talk about it. Let them get that out. Help them get some hope. Help them find other ways to get through life. As Dr. Clark was saying, many of it is internal. If we can trust ourselves and look for internal gratification, it would go so much further than it would looking for outside gratification. Just think, if you had internal gratification, you could live anywhere. Wouldn't be so much where you are. You carry it. Wherever you go, there you are. And you could enjoy life a lot better if you have self-gratitude. Many times people will listen to you say, well, you should go walking, you should do this, you should soak in the tub, you should do all of these kind of things for satisfaction, not use drugs. But they're not going to do it because it didn't come from within. Ask them, what do you do that makes you feel good? that's productive. For me, it's walking. If I have a day that I'm just all over the place, I go walking. I love to walk. When I had a hip replacement, and they gave me 30 Percocets, I think it was. I said, that's the worst thing to give someone who is just coming out of an operation. I can't walk. It's something I love to do. I was crying all the time. I was depressed. And I threw the Percocet out because I was afraid to get addicted to it. I was afraid I didn't want it. But, and that's the first thing that they do, is they give someone who had a major operation these drugs, and people become addicted to it. But to stay ahead of the game, Dr. Sherrod, these things that we can do is just have places where they can talk. Many times they don't need a psychiatrist, because suicide prevention should not be left up to psychiatrists. Really, shouldn't be left up to the emergency room. If you want to bring a therapist in, fine, but oftentimes they just want to talk about the fact that they have no hope, about the fact that they feel devalued, who's doing this to them. They just need to talk about it. And it's not a time when they're talking to give them advice. They don't want to hear that. They just want to talk. You should just, put tape over your mouth if you have to. And if something bothers them and keeps them up at night, and it's small to you, don't devalue it just because it's small to you. If it's large to them, that's keeping them up at night and bothering them, allow them to talk about it and don't pass judgment. Just
To your point about not necessarily all of these things, not having to go to a psychiatrist to be discussed, Dr. Sherrod had kind of a follow-up question. Are there any resources on, for example, like a curriculum that I'm assuming we're talking about some of these other gateway opportunities, right? Whether it's your primary care providers or whomever that you can use to help the people who need to be listening, right? With how to listen, guide folks who are trying to overcome grief or loss or dealing with obstacles, while recognizing that everybody's not going to be a specialist in that area. But to your point, people come in, they enter where they enter, right? And some of us who are in a position to see those folks we don't have the best skills in, to your point, being quiet and letting somebody say what they need to say.
It's really not rocket science. It's just listening and knowing how to listen and letting them guide it. And then if they say something you don't understand, ask them to help you understand that. Why do you feel this about that? And help them talk this out. Sometimes you're it, and sometimes that's all they need. It's not a 1, 2, 3. It really isn't. You're talking about the human being. Nothing is 1, 2, 3. A plus B equals suicide prevention. But there are all kinds of books on how to relate to a person, how to talk to a person, because they have the answers and we have the answers. I'm always telling people, put the notebook down, put the tools down, put your pencil down, and just listen and let your second brain, which is your stomach, let your gut tell you where to go. The important thing is let them talk and listen to them and let them guide the conversation. They will love you for it.
Dr. Barnes, you bring up an issue, especially when you said gut. And if you and maybe Dr. Clark and Dr. Hines or Dr. Kerwin Dawes, how much of this could be related to diet, to interactions with serotonin from your gut, the blood-brain barrier? How much of the psychiatry is actually physiological, or is it all mixed together, that a person's mood, his intentions can be affected by physiological processes in the gut?
There was a time before Rockefeller, before the pharmaceutical companies started pushing drugs. There was a time when they had to deal with natural stuff. how to eat well, to heal and to heal. I mean, I don't know, you guys probably know more about the history of mental health in the Black community more than I do, but there was a time when it was never addressed. And if it was done through what we eat and what we do and the kind of lifestyle that we live. It plays a major part. It plays a major part. There's a doctor at Howard University who is a health fanatic, and she always includes that in her therapy as far as eating right and eating well, because a lot of this stuff that's going on now, there are foods in this country that are not allowed in other countries because there's so many additives, poisons in the food that they're forbidden in other countries. So this fast food stuff that these kids are eating, I think plays a major role. It's what they eat, what they see, what they hear, what they listen to, the social media, the songs the kids are coming out with today, all of that. It's sad. But yes, to answer your question, the foods have a lot to do with it.
Another question I have, and anybody can chime in on this, is there a role for I do a lot of praying in my office, both without patients and for patients and with patients. What is the role that your beliefs can play in this?
A major role, because if you're lost and you have no hope, you have no reason to get up in the morning, and you just don't see a reason for living, hope, prayer, a belief system, all of that is important. These kids, anybody actually who's lost and is looking at death as an option, needs to have a very strong belief system. That belief system will get them through. And it could be any kind of a belief system. They need to be committed to something. They need to be attached to something. Attachment, commitment, and a belief system are three things that I think a person needs to develop to have a reason to get up in the morning.
Thank you. Can we open up the mics? Is anybody else that's not necessarily an MD or a medical advisory that would like to talk to Dr. Barnes? And
So Dr. Clark and Dr. is having trouble getting off mute.
Oh, she thinks we could do it on this end.
Oh, okay. I
Yeah, we
finally
hear you
got
now.
unmuted. Well,
Oh,
I just
they-
wanted to say, if you remember embryology, which I was prompted to do by my acupuncturist, I recognized that, the two things that grow together first are the spinal cord and the gut. So they are intimately related, and attention to nutrition, but also gut health, gut motility, and the quality and character of your elimination are important things to recognize and understand, and are a good key to understanding, or clue to understanding your level of function. Because if you're not functioning, or if you're over functioning vis-a-vis your gut, you're not in good health. I hope that answers your question around that. And then around the issue of prayer, I'm a Christian. I pray all the time, whenever the Spirit moves me, which may be several times a day. But regardless of what ideology you attribute your faith to, the importance of having faith is closely associated with the ability to have hope. So the two are intimately tied. And one of the main things I ask when I'm first interviewing someone is I ask about their level of faith. Do they have any connection with, or attribute anything to any kind of religion or spiritual basis as a modus to operate with if and when I have to deal with issues of faith and hope in their treatment. But I want to go back to what Dr. Barnes said, and that is it does not take a psychiatrist. It can be any level of provider, a primary care provider, a specialist, a sociologist, a nurse, a member of the clergy, anybody who will listen and
Absolutely.
act.
Absolutely. Yeah, I generally like to pull out a belief system. I ask them, do you have a belief system? What do you believe in? And that there will give you a general basis if they are religious, if they do pray, if they are a part of something. But I know with kids, I'm always saying, how do you feel about the world? And if they talk negatively about the world, well, how do you feel about your community? They talk negative about that. How do you feel about your family? They talk negative about that. How do you feel about yourself? If everything is negative, 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 negative down the line, that person is in trouble, and you need to work with that person. That's something that that will keep you staying in front of it.
So can you talk a minute about some of those special phone numbers that people can call, and how do they work, and you recommend them, and how can they give help?
A phone number?
That the CDC has, the 388 or something like that?
988.
988.
They can call 988. Now, I have a list of resources, and on my list is Black Girl Therapy. And there's a whole list of organizations who work together as Black organization to give therapy. They're funded from outside sources, so they're able to help them pay for it. And they get financial information on that. However, I tried to use them for the first time about a month ago. And I should have done this even before I put them on the list, but everybody was using it. So I figured, oh, okay, well, it must be a good operation. And it's like pulling teeth to get anyone to talk to you, to return your call, and I know people are busy, I get that, but it's not as simple as it looks, but I haven't given up on them. There are so many people out there who don't know where to go for help. There's so many people out there who lose patience in trying to get through to the system. It's just not that easy. It's not like it was in the old days where you pick up the phone and talk to somebody. It's just.
Could you put some of those resources that you trust in the chat when you get a chance?
I have them on my desktop. Let's see.
Or if you could send them to me, I'll send them out on the MailChimp. Are there any other people on the call that would like to make a comment or have a question for Dr. Barnes? Not just our doctors, but some of the other people on as well? Don't everybody raise their hand at once.
They're thinking. Let them think.
And we are at the top of the hour.
Okay, we are.
Okay, 1 second, please. I know we're at the top of the hour.
Dr. Kerwin-Dawes was saying if there was a question, if anyone wanted to re-ask the question that had been directed towards her.
Okay. Let's unmute Dr. Kerwin-Dawes.
Can everyone see this?
Yes.
Yes.
Okay, so this is a list. Their books.
This is good. So people can go back on YouTube and read this for yourself. And I will get that list from you also and make sure we have it in our database. Can we unmute Dr. Dawes?
I'm unmuted. What was the question and how can I help?
we had, you had been summoned because Dr. Clark said that you gave the best lecture she ever heard at a Region 1 conference when you talked about the use of marijuana medically. And it had been discussed before if there are some kinds of marijuana that give you an up and some that give you a down. And the question was, I think I raised it, if you have one of those down types of marijuana, can that be an leverage for a person doing suicide, something like that?
Well, there are some that actually do lift you up. There are some that they take for anxiety. There are some for the down more is more like calm and mellow. There are very few that actually, I can't think of anyone off the head that makes you depressed. When they say down, it's more like lay in a corner and everything is just smooth and go sleep.
What they call a bad trip.
A bad trip with marijuana is usually when they mix it with other drugs. So one of the things that they do mix marijuana with cocaine, with crack. There are other herbs that they use in Jamaica that they mix with it because they can say they give you a higher high. So there's even such a thing as lizard tail that they actually grind up with it. That's supposed to give you a really high. But for some people, it's really, they crash really easy and they're out of control. They see things, stuff like that. Most of the strains in regular marijuana, if they're clean, do not do that. It's mostly when they're mixing it. There's some that are actually make you feel really good. The problem also is when people are coming down, that they don't handle it as well. Some people sleep away, just sleep, but some of them come down a little faster than others and can feel quite bad. I have not heard much or read much of people actually committing suicide after marijuana. I think we are seeing in our population, especially post-COVID, an increase in suicide in all the population, not just teenagers, but in older adults as well. But with the teenagers, I think a lot of them are lonely. The society with teenagers right now is everything is talking on the web. They talk on their phones with their hands. There is not as much touch unless they go out with somebody and then they're having sex, which is not actually really, I think, good touch if you don't really know the person that well. So they don't really have a lot of coping skills we're seeing. If what we see is a bunch of people, if they not die, for teenagers, it seems to them like that. If their partner breaks up with them, some of them actually will try to commit suicide. And I think it's because that's the one person they've actually gotten close to, beside everybody else talking on the phone and using emojis, etc. I do think they don't exercise as much. The fast food is actually one of the worst things that we're having now. Probiotics, I think, helps because I don't think people are eating healthier. It does help to balance your gut if you are a little bit healthier. But there are some people that genetically are just prone to being depressed, and you will see it in families. And if you realize you're from a family like that, or that teenager is from a family like that, you have to actually pay attention, try to get close to them and listen, because they're just more prone to it.
Well, thank you so much, Dr. Kervin Dawes. Dr. Barnes, we sure appreciate your wonderful expertise and like to know if you have any final comments before Dr. Hines and myself give comments, and also Dr. Michelle Clark. But Dr. Barnes, thank you.
Thank you very much for having me for a second time. This is such an important topic. So again, thank you for those who are in the room.
Thank you. Dr. Michelle Clark?
I'm here. Excuse me. I'm here. I think we've had an outstanding discussion. It's something that we should return to routinely, particularly given the spikes that we're seeing of self-destruction.
Thank you very much. And Dr. Hines, how are you, my lady?
I'm doing well. And again, Dr. Barnes and Dr. Clark, thank you again for continuing to discuss this topic, and especially, focusing on some of the ways that it shows up different, right? So that then we can be a little bit more attuned to what might be going on around us. And for everyone, I think what you were saying about the human aspects of just being able to listen, we all have the skills if we try, right, or the ability potentially to be able to be a listening ear. And then hopefully for, whether you're a professional in that space or not, we can exercise that more so that we can hear what some of these people are trying to tell us. Because some people are trying to tell you that they're hurting in these ways. So this is a really great discussion. Thank you.
Absolutely. And it's very hard. Let me just say one more thing, Dr. Maxey. It's very hard for people to ask for help. It's very, very hard. And if you sort of detect it, you see that they're not acting themselves and there's something wrong and you can't put your finger on it, it's okay to take them aside and just say, I notice that when people go through what you're going through, sometimes they think of ending their life. I'm just wondering if that's what you're thinking. And say it in a way that you're not going to pass judgment and that you understand. Okay.
That's very good. That's very good. So for my final words, I want to mention a couple of things. I do believe that having a strong faith in God is something that's very important. But I was taught to look at faith as a bridge that allows grace and mercy to go across to you, from God to you. So that faith is that bridge. Coming up for our next 2 weeks, we're going to have a talk next week going back to the Old Testament, back to Genesis 1, and we're going to talk about some of the basis for this turmoil that we have in the Middle East now, and what is the spiritual cause of it, what's the genetic cause of it that's going on. It's going to be presented by Dr. Shaveen Jones, who has both a master's in Greek and Hebrew. The following week, we have a number of general officers of the U.S. military, including a retired 3-star Navy Admiral, Dr. David Brewer, who's been with us several times before. And he's recruited a former Air Force 3-star general who has also been a prisoner of war and also an Air Force judge advocate. And they're going to discuss these issues from an academic standpoint, not taking sides, but just present this and how it affects our health since we're part of the whole world. So I hope you join us for our next 2 Sundays as well. And again, thank you so much, Dr. Donna H. Barnes, and I really appreciate Dr. William Lawson for introducing me to you. Have a great Sunday afternoon, everybody. Simon, thank you so much for your help. Have a great day.
Thank you.